Hello everybody, I am Dr. Srikanth, Senior Consultant Paediatric Ophthalmologist from Apollo Spectra Alwarpet. So I'd like to thank the management for giving me this opportunity to talk on Facebook Live with you all. So without further delay, we would like to first of all get into what we are going to talk about today, and it is on squint. So squint, as we all know, which we also call as strabismus. So this is basically something which in layman's term we call it as a squint, which means that the eyes are not aligned well, aligned straight. So when one eye is looking in one direction and the other eye is in some other direction, then we call it as a squint. So it can be either horizontal, or it can be a vertical, or it can be even a rotational squint. So these are various types of squint which we usually come across, and this is basically more commonly seen in children, but can also be seen in adults due to various other reasons. So we'll tackle one by one as to what causes these squints, how we can assess these squints, how we manage these squints, and whether we need surgery for almost all these cases or other alternative options. So this is what we will be covering in today's talk. So as far as squint is concerned, as I mentioned, it's usually caused in children, and the two common types of squint which we see in children are either an inward squinting or an outward squinting of eye. So amongst the inward squinting, inward moving of the eye, where the parents feel that the eye sometimes goes inside, or sometimes the eye itself starts to drift outside. So it can be constant or it can be intermittent. So once in a while you notice that the eye is not aligned properly, and the next moment you realize, you see that the eyes are perfectly normal. So they are confused, and that's what brings them to the doctor to maybe confirm whether the eyes are really straight, or if there is anything else happening, whether they need any further assessment. So amongst the inward squinting, the two common types of squint that we commonly come across are infantile esotropia and accommodative esotropia. So these are the two most commonly noticed inward squinting of eyes in children, and they occur very early on, some below 2 years of age or around 3 to 4 years of age, and the management for both is different. So sometimes whenever you bring a child with inward squinting of eyes, most of the times there may not be actually a squint, and it's probably the eye position is straight, but it's basically the shape of the eyelids and the skin around the lids which makes it look like a squint, but actually there may not be any squint at all. So in those cases you just have to observe. But if there is an actual true squint, the first thing which the doctor would advise is to look for any power. Okay, if the glasses power, that is done by putting some eye drops. We dilate the child's eye, look for any causes inside the eye, whether there is anything happening inside the eye which is causing the squinting of the eyes, some retinal problem, some nerve problem, or any power problem. So sometimes the glasses power might be very high, which in turn can lead to the eye to squint. So when dilatation is done, you do the retinal examination, and the optic nerve which connects the eye to the brain, that is also checked, and then we basically rule out any intraocular causes or the eye causes of squinting of the eyes. So if there is any problem in the retina, there can be a nerve itself can be malformed, or the retina can be not well developed, or there can be a tumor inside the retina. So these are some causes which can lead to poor vision. Any poor vision can lead to squinting of eyes. If there is a glasses power, the first thing which needs to be done is to put a child on glasses, and many of the squints are just corrected by giving the child the glasses. So as I mentioned, there are certain inward squinting where the plus power of the child is quite high, and when the plus power is high, just by putting the glasses on, it's called an accommodative squint, where just by putting glasses on, the squint is almost corrected. But it's not like when the child is not wearing the glasses, the squint will still be corrected. It's only when the glasses are worn, the eyes are aligned properly. When the child removes the glasses, you may still notice the eye to drift inwards. The other type of squint which is commonly noticed in kids is the outward deviation or an intermittent exotropia squint. So intermittent exotropia is, as I mentioned, it's an intermittent squint. So sometimes the eye looks straight, sometimes the eye starts to drift outside. So this basically again sometimes can be noticed in children who have glasses power and they have not used glasses power. So as I mentioned before, if a plus power is high, it can lead to an inward squinting. Here, when the eye starts drifting outside, most of the times you notice the child to be having a minus power, either a spherical power as in myopia or a cylindrical power as in astigmatism. So high minus power can lead to eye drifting outwards. So whenever you notice children who have high plus power or minus power, as I mentioned, they need to be started on glasses right away, and then probably 2 or 3 months later we again reassess how their squint is controlled with the use of the glasses. Vision and squint both need to be controlled with the use of the glasses, and once the child wears the glasses and notices the difference in the quality of vision, automatically the child takes to the glasses and wears them. So sometimes there is some apprehension among parents whether the child will actually wear those glasses which are given, but if there is a real need for glasses, when the child notices a true difference between wearing and not wearing, automatically they will start wearing the glasses, and that improves the alignment of the eyes as well. As far as other risk factors for children getting squint, children who are born prematurely, children who have a very low birth weight, they are more at risk of developing squint. Children who have other developmental issues, they also tend to have a more tendency for squinting. Some children with syndromes, many syndromic associations, they do also tend to develop a squint. So these are various conditions where the child is more prone to develop squinting of the eyes. As far as management of the squint is concerned in children, first step, as previously mentioned, would be use of glasses and correcting the refractive error. So always we have to look for one, the vision, quality of the vision, how the eye alignment is, whether it is one eye which is always squinting or is it an alternating squint. When I say alternating squint, I mean whether both the eyes take turns to squint, or if it's only one eye which constantly keeps getting deviated and the other eye is always straight. So the reason why that needs to be assessed is because if the eye is alternately squinting, it means that the quality of vision is almost equal in both the eyes. But if it's only one eye which is constantly deviating, then probably during the early years of the growing of the child's neural development, the eye to brain connections might not be as well developed in that eye, because the brain has a tendency to suppress the eye which is squinting, suppress the development of the neural connections in the eye which is squinting. So that is what we call in general terms as the lazy eye. Okay, we call it as amblyopia. So amblyopia or lazy eye is something which means that the neural connections from the eye to brain are a little weaker as compared to the normal or the dominant eye. So here, whenever there is an eye which is squinting, and if the child also has amblyopia or lazy eye, always we need to correct the lazy eye or the amblyopia first, and then we go on to correcting the squint part as well. So sometimes just providing glasses can improve the vision or correct the lazy eye, or sometimes we may need to do certain exercises like patching of the eyes and forcing the child to use the eye with poorer vision. So once the lazy eye is corrected, then we probably go on to try and correct the alignment of the eyes, either using various options that we have at our which are available to us. The other squinting, as I mentioned, is an intermittent exotropia. There, what we basically look for is the control over the squint. So if the control over the squint is, there are three grades. You can call it as like the good, moderate, and poor control. When the control over the squint lies in the good to moderate range, then we basically try and keep observing and do certain alternating patching therapies, give them glasses and keep observing them on a regular basis, but and also keep observing for their stereopsis or the 3D vision of the child. So 3D vision is basically both eyes focusing at one point. Like when you go for watching 3D movies, you see things which are coming out of the screen. So those are certain factors which are, these are things which can be affected when the eyes has a squint. The binocularity or the 3D nature of the eyes can be lost because of the squint that happens in the eye. So binocularity needs to be constantly assessed every 3 to 4 monthly once, and if there is the eye control goes into the poor range or the squint leads to loss of stereopsis or 3D vision, then it's the time to probably think of doing a surgical correction. So as far as managing the squint is concerned, one, as I mentioned, is the glasses. The second option is certain exercises, early stages of early stages of squint can be managed through various convergence exercises or eye movement exercises. Then we also have sometimes prisms. So prisms are usually not for very large angle squints. So if the squint angle is small or if there is a problem of double vision, then we use prisms as an option for controlling those squints. But last stage of correction would be a surgical correction, and in a surgical correction basically we usually plan that for children where nothing else would be working, if the angles are too large or if the control is poor, then surgery would be the only option in those situations. And surgery, if at all, if it's needed, probably needs to be planned a little earlier, because the neural connections are very plastic, they are flexible. So if at all the brain needs to start using both the eyes together, probably it would be better if they get more time when we plan the surgery earlier, so that once the new alignment of the new position of the eyes the brain gets, it will be able to start using both the eyes, or binocular vision can be started off earlier itself. So if at all surgery is done, it may be done on one eye or both eyes together. So again, the doctor would be assessing the angle of the squint, the eye which is dominant eye, how much correction needs to be done, what the post-operative position of the eye should be. So whether two muscles are needed in one eye or one muscle, or so basically based on the angle of the squint and the position of the eyes, we decide how many muscles are need to be done at one sitting. So once the surgery, so basically there are eye muscles which move the eyes in various directions. So it can be inward movement, outward movement, upward movement, downward movement. So there are various muscles which eye have which moves them. So these are the muscles which need to be altered in its position as well as rotational ability. So these when we do the surgery, we have a certain fixed table which we follow for the amount of squint, how much correction needs to be done, and basically that's what is done during the surgery. So overall the assessment of a squint is most important, then the planning of the surgery is important. The earlier, as I mentioned, the squint is done, the better chances for the eye positioning and the longevity of the eye position to remain straight is concerned. To get good binocular vision, again, earlier the surgery is done, the better the outcome. Does squint recur? Does it keep coming back again after a surgery? Yes, it can. It can always happen. But if the vision is good, the chances of the squint to recur is much lesser. But if the vision is poor in the eye, the chances are much more. So you have to keep that in mind as well when we are correcting the squint. As far as adults are concerned, there are various other conditions which can lead to squinting, and when in an adult there is a development of sudden development of squint, it could be because of something underlying. It could be a thyroid problem, a condition called myasthenia gravis, some trauma or injury to the structures or bones in and around the eyes. So those are common conditions which can lead to squinting of the eyes in adults, and when they do develop the eye misalignment in adults, it will lead to what we call as double vision or diplopia. And in them, diabetes again is one of the common factors, one of the common conditions which can lead to double vision or squinting of the eyes, and they may need full blood test as well as systemic assessment to find out what the cause is. In such cases, sometimes an MRI of the brain and orbit is needed, and we need to find out where exactly the pathology is lying and probably treat that. And then if the required, they may, if the angles are small, you can give them some prism glasses, and that itself can correct the problem of double vision as well as the squinting. And if the angles are large and if it's not correcting by itself, then surgery again would be the last option, apart from controlling whatever is causing the condition. So overall, this is how we assess and manage squint. So in our facility at Apollo Spectra, we do have almost all appliances for managing squint effectively. So earlier you correct, the better the options for resolving, as well as for the brain to start developing a binocular vision. So yes, so in children, never hesitate as far as correcting the squint is concerned. Surgery has very good results and long-term results also, not only for the functional aspect of the eye, but also for the personality development of the child, because sometimes we do have noticed that many kids do find that they are low in confidence as far as they are concerned at school, because of what they go through with other kids when they do make fun of their eye positions. So yes, it does help them by correcting the squint. So yeah, definitely that option can be considered as a viable option for children. So yeah, so with that, I would like to conclude today's talk. Thank you very much for your patient listening. Thank you.